So we'll get started, but thanks everybody for coming, and we all know our favorite speaker, Dr. Cohan. So yay, we're happy everybody's here. And we've got Jerry taping for us. Of course, thanks Jerry for coming all the way up to from San Diego. And because I have a couple patients that's already called me and said, I can't come tonight, but is Jerry going to videotape? So I said yes, so yay. So we'll go ahead and let Dr. Cohan get started.
Thank you very much. It's a pleasure to be in this venue again. Thank you for coming out to listen to me again. I'm sorry for those of you who've heard me before. It's going to be somewhat of a review of what we've talked about before, about hormones. Yeah, we're going to talk about hormones. And I always like it to be interactive, so people who have questions or comments, you're welcome to participate. I always learn from interacting with you guys, and I'm sure that other people may have similar questions to what you have. I want to just start by asking how you guys would define a hormone. I've done this before, and it's always fun to see what people say. Definition of hormones, other than things that make us feel terrible sometimes.
Diane, what do you say?
It makes you crazy.
Yes. They do, they could make you, there has to be a delicate balance between hormones so that body functions are regulated properly. So
It's like a communicator or a transmitter?
Yes. Between
Different cells, organs.
Exactly. So that's the way I look at hormones, and I think it's a good framework to try to understand the actions and the biology of hormones. Is that really they are chemical signals or messengers, and these messengers help communicate from one cell in one part of the body to different cells in the rest of the body.
So it's like the post office.
It's like a post office.
And since
Yes.
I don't have any hormones, I got no post office. Everything of mine's going in the dead letter file.
Yes.
I don't know. I just think it's perplexing all the way around. Because everybody else gets like hyper and wacky and wild, and I sit there and just look at them and go, okay.
You're lucky.
Yeah.
Because I got no flight, I got no fine tuning, hyper acuity to most anything, feeling wise or emotion wise. I got blended emotions. That's what it looks like to me. I don't know how you drink that up, but you can't just like invent it.
You can't.
That's what I'm saying.
As we'll talk about, hormones are very intricately regulated and extremely complicated. So a hormone or these chemical messengers are released by the various endocrine glands of the body, and these endocrine glands are everywhere in the body. The pituitary gland, of course, is one of those glands. But just to prove how diverse and show you as an example of how diverse and far-reaching some of these hormones are, let's just take a couple of examples of different hormones. So you have, for example, the hormone gastrin.
Come on in, guys. Nice to see you. Thank you. Come on.
And we're not going to just talk about pituitary hormones, but we're going to talk about various different hormones, because all of these hormones will affect different body functions. At the end of the day, you'll see that all of them will affect quality of life and day-to-day functioning. Welcome. So a hormone gastrin is a hormone that is made by the pancreas. Okay? So the pancreas makes the hormone gastrin, and this gets released into the bloodstream. So it gets into the bloodstream, and from the bloodstream it gets pumped essentially everywhere then into the body. One of the places that it ends up at is a portion of the stomach. This is the stomach. which actually happens to be very close to the pancreas that made gastrin. But this hormone gets released into the circulation. It goes everywhere in the bloodstream. And among those places is the stomach, where at the stomach there's a receptor for it. So at that level it's recognized. So hormones require receptors in order to exert their effects, binds to this receptor at the stomach and tells the stomach to make hydrochloric acid, an acid that then is involved in digestion. So this hormone gastrin is a true endocrine hormone, which means that it is, endocrine means that it's released into the bloodstream, circulates in the body, but then exerts its effect at some level, and in this case, in the stomach. So a hormone made in one part of the body is now affecting the other part of the body. These two areas of the body, the pancreas and the stomach, anatomically are very close to each other, yet yet the hormone has to circulate a long distance to get to its site of action.
Now, Dr. Cohan, if someone were to have a pancreatic tumor, can it overproduce a hormone of gastrin, or because I know they can overproduce other hormones of the tumor, but could it have a gastrin tumor?
Absolutely, yeah. So we'll talk about the hormonal glands are susceptible to several different disease processes that can be categorized into 3 or 4 different processes. One is formation of tumors. So all endocrine glands, for some reason, are susceptible to tumor formation. So the pancreas can develop a tumor that now overproduces gastrin. So what would you think if now a lot of gastrin is produced?
I would think your stomach would have too much acid, and it could burn like a hole in your stomach.
That's exactly what happens. So if you have a tumor in the pancreas that's making gastrin, and now it's making it in a deregulated fashion because there's no control, and this tumor is pumping out the signal, this chemical messenger, that messenger is continuously telling the stomach to make acid without any relationship to whether or not there's food in the stomach. Normally, the pancreatic cells that make gastrin release that gastrin when there's food in the stomach. But when you have a tumor, then you're constantly making acid and you can get an ulcer. So tumors are one problem that can affect the endocrine glands. The other problem that affects endocrine glands are autoimmune diseases, meaning that the immune system can attack, your own body can attack the gland. So what would happen if the immune system begins to attack the pancreas? Well, you don't make gastrin, so you're going to have problems with digestion, because now your immune system is attacking this gland and it's making this gland non-functional. The pancreas also makes insulin, so when you attack the pancreas, then you can get type 1 diabetes.
Oh, yeah.
So glands are susceptible to autoimmune diseases, diseases where the body just begins to attack itself. Hormonal disorders can also be caused by problems at the level of this receptor. You can think of receptors as locks and keys. If the key fits into the lock, it will open the door and it will result in a chain of events that then lead to the release of acid in this case. If the lock or the key is slightly altered, then this fit is not going to happen. So no matter how much of this hormone you have, it's not going to be able to bind to the receptor and result in the release of acid. So hormonal problems can develop from blocks or problems with the receptors. So in broad categories, hormonal disorders can happen if there is a tumor that leads to overproduction. For example, in the case of a gastrin-producing tumor, a gastrinoma, it can result from autoimmune diseases where the immune system attacks the gland. It can result from problems at the level of the receptor, so the hormone is being made, but it can't function. Also, hormones are very sensitive to nutritional perturbations. So in situations, for example, where the body is nutritionally not right, whether there's obesity or whether there's malnutrition, a lot of times hormones are not properly released. Let's talk about some examples of nutritional conditions. Well, what happens to children who are not given enough food and they have caloric restriction? What's one of the things that happens?
They starve.
They starve.
And they're skinny.
And they're skinny.
Malnutrition.
And hormonally, and they don't grow.
Right.
So they don't grow. So that's exactly right. So when the body is in a state of nutritional deprivation, growth hormone is not released. Mm-hmm. And so in childhood, if a child, for example, is restricted calorically, or even let's say an adult, or an adolescent who is anorexic, could develop growth hormone deficiency because the pituitary gland, when there's not enough nutrients, will stop making growth hormone. And so during childhood, growth won't happen. Or let's say that if you have a person now who exercises excessively, and there are people who, for example, women who may run in long distance marathons and become they lose a lot of body fat, that can lead to the disruption of the hormonal signals from the pituitary that regulate the menstrual cycle. So usually in that context, menstrual cycles stop.
I hear that a lot, yeah, from runners.
So that's a form of a nutritional deprivation that leads to a hormonal dysfunction. So again, hormonal problems can occur because the gland develops a tumor, which turns out to be quite common. So pituitary tumors are relatively common. 1 in 10 people can have a pituitary tumor. Thyroid tumors are even more common.
Yeah.
30% of women, depending on which population you look at, can have tumors in their thyroid. The nice thing, though, if there is ever a nice thing about hormonal diseases, is that most of the tumors that affect the endocrine glands are benign. So they're not cancerous tumors, but they are nevertheless problematic because they lead into disruption of the signaling. This post office is now like 2013 post office. Even if you put the right address and the right stamp, it may not get to the right place, right? Yeah. So it's dysregulated. It's dysregulated. There's not enough, there's not enough people to transmit those signals properly, or the system is overloaded.
So what I can't figure out is why doesn't it do a retrofit then? I mean, like when my husband had his stent put in his heart, his body made a bypass and went through his shoulder and just kept ticking along until they put the stent in. And then it reorchestrated itself around the stent and put everything back in his shoulder where it had bypassed. So why doesn't this hormone thing do the same thing kind of deal? Why doesn't it just take another avenue and juncture in your body instead of just either overload or doesn't react at all? That's my curiosity.
It's a good question. I don't know the answer to that question. There are some built-in redundancies in the hormonal system, and we'll talk about that. Maybe we'll talk about it now since you asked the question. If you think about critical body functions, let's say the critical body function of maintaining blood sugar in a normal range, that important body function is actually regulated by more than one hormone. So, and the same goes true with like salt balance and blood pressure. So life-sustaining physiological processes are actually regulated not just by one hormone, by multiple hormones. So there's a little bit of a redundancy, like you're saying, exactly like you're saying, in that fortunately there is some backup. One of the problems is that if this tumor or this problem is at the pituitary gland, that pituitary gland is regulating about 7 hormones. So one problem at that site can then throw a lot of different hormones off. So even if you have a lot of built-in redundancy in the system, like for example, blood sugar is not just regulated by insulin, it's regulated by cortisol. It's also regulated by growth hormone, which you wouldn't expect, but growth hormone helps in the regulation of blood sugar. And so fortunately, if you have just growth hormone off, you can probably still maintain relatively good sugar metabolism as long as insulin and, for example, cortisol is intact. So important physiological functions are regulated by more than one hormone. The other side of the equation is that one hormone also regulates or has many diverse effects on various different body parts. And so, for example, if you take one hormone, cortisol, you see that it has not just an effect on maintaining body composition, it has a role in maintaining blood sugar, blood pressure, muscle mass, bone health. So a single hormone can have multiple different effects. So there's some redundancy, which is good, but it's not always perfect, especially if the problem is at the master gland, which is the pituitary gland. So just so that you have the list, so tumor formation, autoimmune, receptor problems. Receptor problems are actually very interesting, could be very interesting. So let's say that you have a genetic male, okay? So this is a real patient of mine, a genetic male. So this person has an X and a Y chromosome, right? So genetically they're a male and this person is producing testosterone. But let's say that at the level of the body parts like the body, for example, hair and the testes and the sexual organs, there's now a problem with the receptor, and therefore that testosterone cannot bind to the receptor. Okay? So this is a genetic male, XY chromosome, is making lots of testosterone, but that testosterone is inactive essentially because it can't bind to the receptor. There's a receptor mutation. There's a problem with the receptor. Testosterone cannot form that lock and key mechanism and result in the formation of, for example, facial hair or the formation of secondary sexual characters. So that person is going to look like a woman.
So you test the testosterone and it shows up high, but you don't see any physical...
Because the problem is at the level of the receptor.
And is there a test you can do other than just looking at them and say it's at that, or is there...
Because this is a problem. So receptors are usually proteins.
Oh.
So receptors are proteins, and proteins are encoded by genes. So the genetic material, the genetic blueprint determines the receptor. So if you have a mutation in the gene that encodes that receptor, and something goes array, and that gene is now making a defective receptor, you will never get the testosterone level to act, but you can test for the genetic syndrome.
Okay. But no matter how much testosterone, is there any...
So what do you do?
Yeah.
So what do you do with that? Those patients are, because they're phenotypically, meaning on the outside, look like women, you treat them as women. And you end up giving them extra estrogen to help develop of the breasts and so on and so forth. So now this is a rare case, but it's an example of how receptor problems are important.
But since they're doing the genetic markers, they'll be able to pick that up.
Correct.
As like they're doing the BRCA one that everybody's talking about now, since the actress had her breast removed. Now everybody's starting to go, okay, so what's my marker for this? What's my marker? So
Right.
everybody wants to know the initials and the numbers that go with the marker.
But like in this case, which is very rare, you said they look like a woman and you treat them like a woman. Do they therefore, because of no testosterone, feel like a woman? I mean, do they think like, oh God, help me.
I'm I'm not sure how women think sometimes, and I certainly don't know how this person thinks. But I mean, I think that she is you know, there's no, if you look at her, there's no difference than any other woman that you may see.
Yeah.
There's absolutely no
I guess
difference,
what I'm
especially if
asking-
she was treated properly, which is, you know, early diagnosis and understanding that this is a genetic problem, and you know, treating them early, you end up with a woman.
Yeah.
She obviously is not going to be fertile, but anyway, you get, you know, it's a phenotypic woman, so. I don't know how they feel emotionally or psychologically, but she's happy. She's married.
Okay.
Yeah.
Her husband knows that there's something different about her, but he doesn't know all the details.
Okay. Interesting.
Yeah, so she's fine. I mean, one of the main problem with this condition is osteoporosis, because they don't have the action of testosterone and hormones, so you have to really give a lot of estrogen, usually in contraceptive doses. So anyway, so receptor problem. So knowing that receptors are important also affords us a mechanism of treatment. So let's take, for example, now a tumor in the pituitary that is now making too much growth hormone. Okay? Now, growth hormone has lots of good properties. It maintains growth, linear growth during childhood. It helps keep us lean. It provides important effects on muscle and bone. But when growth hormone is produced in excess, lots of bad things happen. Diabetes, arthritis, heart disease,
Tumors, right?
tumors in the colon and perhaps other places in the body. And so if you have, so growth hormone, just like any hormone, I'm talking in general principles, because if you understand general principles, then you can understand all the different hormonal problems. So if a person has too much growth hormone because they have a pituitary tumor, and let's say that tumor is very large and it can't be removed in its entirety, or that radiation doesn't work to treat the tumor, we know that ultimately growth hormone binds to receptors. It binds to receptors on muscle. It binds to receptors on the heart. Now, what if you were to find a medication that prevents growth hormone from binding to the receptor?
That'd be good.
Well, that would be good, because then what you've done is that even though that growth hormone is made in excess, it can't have the negative effect on the different parts of the body. Just like that woman that I mentioned to you did not have testosterone, so its actions couldn't be visualized or elaborated in the body. So we do have blockers of growth hormone binding to the growth hormone receptor, and that's a very effective treatment for acromegaly, which is a disease of too much growth hormone. We also have receptor blockers now for the treatment of Cushing's disease and Cushing's syndrome, where there's a tumor that is making excessive signal for cortisol, and cortisol can have lots of devastating effects on the body. And sometimes we cannot get to that tumor. The surgeon cannot find it. It's too small or it's invasive and cannot be removed in its entirety. And so we're left at not being able to address the tumor itself, but we can have a blocker so that the cortisol, even though that it's being released in high amounts, it can't bind to the receptor and it can't then cause the ill effects of excessive cortisol. So the receptor problems are problems, but also we can use those to our advantage in trying to come up with medications, knowing that a hormone, in order to act as a signal or a messenger, needs to bind to a receptor. Okay.
But what I find too that's interesting about hormones, even though it's like they'll say you don't need prolactin, you know, that unless I mean, like if you're not pregnant and whatever, that really prolactin doesn't do anything. However, I've seen enough patients that when their prolactin is off, and everything, or you know, or that they don't feel good. So, and it gives them still bad effects.
That's correct. There's a lot that we don't understand about hormones. I mean, prolactin is a pituitary hormone that regulates lactation and breast development in men and lactation in women. And sometimes when prolactin is elevated, even if the person is not having problems with lactation or breast development, there could still be some undesirable side effects from the prolactin, and that could be problems with mood, problems with energy, quality of life. So probably what's happening is that prolactin is having effects at other sites, perhaps the receptors at the level of other tissues that could mediate this effect. The other thing is that sometimes when one hormone is off, it disrupts the formation of another hormone. So, and it could be that that's why, for example, an abnormal thyroid level can cause some other hormonal problem, is because these hormones are not just acting in these nice straight lines that one hormone is released and it affects one body part. One hormone can affect another hormone's production. It becomes really complicated. Very, very, very complicated.
So with normal behavior then, the growth hormone is just supposed to what? Enhance the heart muscle to work at distributing the blood, and instead with the growth hormone like that, it just like makes the muscle expand and go beyond the normal ranges that were expected to pump the blood. Is that right?
100%.
See,
You nailed it. You nailed it.
That's what I was trying to figure out.
So you nailed
Every
it.
time somebody does something, when it comes to my heart, they'll go, oh, that, front side of your heart, there's just no hope for that because it is just, the muscle is just too expanded and extended and.
Right. So what
Yeah,
happens?
yeah.
So most muscles, if you work them and they get bigger, they're adaptive. They're nice. You can lift heavier things. You have more stamina, endurance.
But its
For the heart,
original program was to just pump the blood.
sufficient. Right. Not excessive.
Boost and expand.
Right. If you start to make the heart muscle grow, what happens is that then the heart cannot function properly as a pump. Because the heart, at the end of the day, without being disrespectful to the cardiologist, the heart is a pump to pump blood. Nothing else.
That's its job.
That's its job. It's just, it has to be a pump to distribute blood through your body. And for that pump to work well, you need some growth hormone in order to make it a strong muscle. But if you give too much and now the heart is abnormally thickened, what happens is that the internal part where the heart fills with blood can't fill properly anymore because it's got what we call concentric hypertrophy. That in a circular fashion, that muscle is too thickened. It cannot relax properly. It cannot fill with blood, and it cannot then pump it forward. So it can only have a limited capacity of blood that it can fill, and therefore it can't pump out adequate amounts to the rest of the body. The other thing is that the heart has valves. So every chamber of the heart, like if you have the ventricle, which is the strong pump, it has a valve which separates it from the other chamber of the heart. If the heart is thickening and enlarging, what happens is that this valve, which is supposed to open and let blood move forward and then close and not let blood flow backwards, because the heart now is big, it's not going to close and you're going to get regurgitation or backward flow of blood. So what happens is you get congestive heart failure. You get congestion. The blood flows backwards. It congests the heart. You're in a congested situation. And so, too much, the bottom line, and we all know this, too much of a good thing is not good. So too much of a good thing is counterproductive. So,
What bothers me is I had to do a post-op thing, and then my EKG went haywire, and then they put me through a whole deal of stress tests for 2 different days. And then they put a heart guy in my plan, and he's going, oh, well, I'll just do an angioplasty. I'm sitting there going, I'm not too sure with acromegaly and the complications. That's exactly the right treatment.
that's right. So
So I'm
acromegalic.
sitting there going, I think I'd better run this by a couple of other people before anybody gets like on their high horse and just your regular fare. So that's what I'm up against all the time, is trying to tell these people to not like, don't do anything extraordinary, and please check and cross-check my file before you do something that we're both gonna regret. And I can't convince them of that. They just wanna still put me in as a regular, normal functioning human being. And, oh yeah, I'll just take care of that. Ooh.
I think that's a good thing for all of us to make sure that we always, you know, with any kind of illness, that we're always double checking doctors.
And especially if you have a pituitary or a hormonal problem, you know, a lot of times a brilliant cardiologist may not, you know, who may be able to do a brilliant job at an angioplasty, may not be as knowledgeable about the effects of hormonal dysregulation or disruption on the body part. So again, you're absolutely right. Acromegalics usually don't get the typical coronary artery disease. They don't get the hardening of the arteries and the blockages. They get this form of a stiff, non-functioning, you know, improperly functioning heart. So usually they don't get the blockages. They could. I mean, you know, most of us are prone to hardening of the arteries because of cholesterol and other things, but the pathophysiology of acromegaly, of too much growth hormone, is not really causing a coronary event. It's causing valvular dysfunction, congestive heart failure. It's causing arrhythmias of the heart, irregular heartbeats, skipped heartbeats, extra heartbeats, because you also, as the heart expands and the muscles are hypertrophied, the conduction of the heart is affected. So I think it's important that you, for patients who have pituitary or hormonal problems, to remind your other treating doctors that you have this other condition, so that there'll be some additional thought given. I mean, in an ideal world, every patient should have additional thought about their conditions, but particularly in people who have a hormonal problem.
What about bicycle races? Like me, I raced for 15 years. All the races have more larger than a normal heart. Would that be detrimental later in life, or?
The effects of over-exercise could have a detrimental effect. There are some studies that suggest, and I think it's hard to draw big conclusions, that not exercising is bad for you, that over-exercising can also be bad for you, and so that you just need the right amount of exercise. So I think that there's a lot of other benefits through exercise that the body gets, so that perhaps some of the effects on thickening of the heart muscles is offset by some of the other benefits. So as the heart is exercising a lot, it is able to function better at a lower heart rate. It's a very adaptive process. So that's a good thing for the heart. The heart rate is down, the heart is pumping in a more relaxed fashion, so you have that benefit. But yes, I think that if you end up in a state of over-exercise and over-utilization of the heart as a pump, it will wear out, probably.
Because people like Jan Ulrich, you know, the competitor of Armstrong, who placed second 6 times. And it's one question Oprah Winfrey didn't ask: if you didn't win, who should have won? He has a resting heart rate of 32.
Right.
Wow.
Which if I had, I would pass out. Yeah. So he's able to, absolutely I would pass out. So if he's able to maintain good cardiac output, yeah, good blood flow at a very low heart rate, it's a very adaptive thing. So the heart, that's a nice thing about exercise. There's lots of other nice things, that your lipids go down, your blood sugar is better, all of these have favorable effects on the heart. The problem with acromegaly and too much growth hormone is that you end up not getting any good benefits anymore. The high growth hormone not only is making the heart thicker, it's making your sugar go up, so you're diabetic now. It's causing cholesterol problems, you're gaining weight, you're having a lot of other negative metabolic effects that are then causing a bad effect on the heart. So I think exercise is different. I do believe that over-exercise is bad for your body, just like we started off by saying.
All right.
That over-exercise is bad.
Right,
over-exercise is bad.
Because, you know, these races, they train when they ride, in the season, they ride from 700 to 1,000 miles a week.
Wow, that's excessive. But
Like
you know,
when the
also,
telecom team was over here 10 years ago, 8 years ago, I rode with Jan Ulrich here in Griffith Park. And, I rode about 2-3 times a week, And we're riding good brisk pace, and I'm looking, and I said, "What's your heart monitor?" And mine was 162, his was 121.
Yeah, it's fascinating.
I mean,
And
unbelievable.
so there's tremendous adaptation that happens. I think for the most part, it is a good adaptation, but you weren't here, Dean. We talked about over-exercise in women results in their cycles going away.
Right.
And what happens? They begin fracturing bones right and left. They get stress fractures because they don't have the reproductive hormones released anymore. So I think an excess of a hormone and an insufficiency of a hormone is bad, and also I think exercise also is going to be problematic. Okay, let's just move on with some general principles about hormones. There are fundamentally two different types of hormones. If you want to categorize it, perhaps three, but really two main types of hormones. Some hormones are what we call peptide hormones.
They like water or?
Yes, so the peptide hormones are actually hydrophobic. They don't like water. Usually these peptide hormones are, get digested by the stomach acid. So the proteins, they're proteins. And if you take them orally, they get digested. They circulate in the body usually by themselves. And then you have steroid hormones. So the peptide hormones are things like insulin, growth hormone. The main reason why I make a point about the peptide hormones is because these hormones can't be ingested, they have to be injected. So that's why insulin and growth hormone and some of the other hormones require injectable route, because they get digested by the stomach acid. And then we have steroid hormones. Actually, I think, Charmin, you're right. These peptide hormones like water. The steroid hormones are hydrophobic, and they don't like water. And the steroid hormones usually are bound to carrier proteins so that they get sort of insulated from the bloodstream. And so the steroid hormones are things like cortisol. That's the main form of steroid hormone. Of course, testosterone is a steroid hormone. And these steroid hormones can be taken orally because they're not proteins. They're not going to get digested. Because steroid hormones are bound to carrier proteins, anything that affects the carrier protein, any state or condition that affects the carrier protein can affect the level of the steroid hormone. And that has important implications in how you measure them. But the most important implication is that some can be taken orally and some have to be injected. So if you wonder why is it that you can take, for example, cortisol orally, but you can't take growth hormone orally, it's just because of the different structure of the hormone. Okay, now an important feature of hormones is that they have rhythm. Okay? This is an important, rhythm. They have rhythm. Hormones aren't just released all the time. In fact, if some hormones are released all the time, it becomes counterproductive. So, of course, if growth hormone is made excessively all the time, that's not good for you. We talked about that. If cortisol is released all the time, it's not good for you. It causes lots of damage to the body. So it turns out that hormones are released in pulses in a rhythm. Some hormones have a daily rhythm. So they have a rhythm where, for example, cortisol is made mostly in the morning and made in small amounts during the rest of the day. In fact, by midnight, cortisol levels approach zero in our body, or close to zero, or close to the level that we can actually measure it. So cortisol, some other hormones have a daily variation, a daily rhythm. And if that rhythm gets affected, then so does the production of the hormone. Some hormones actually have an hourly rhythm. Growth hormone is an example of a hormone that has an hourly rhythm. So you can have a lot of growth hormone produced this hour, and then 30 minutes later, you can have very little growth hormone produced.
So when should you inject it?
Because most of the pulses of growth hormone are during sleep at night, we usually time the treatment of growth hormone to nighttime, to bedtime.
Inject it at night.
So growth hormone is interesting because it's made in little pulses, but most of the pulses are at bedtime. So if these are growth hormone levels and you have big pulses and small pulses during the day, it turns out that in general most of it is happening during sleep. So we try to mimic that by giving growth hormone at bedtime.
So isn't it interesting that our growth happens, like for kids, that's why you need to go to sleep and get good rest, because it's when they're going to release growth hormone. And then cortisol, which keeps us up, that was in the morning. So at least whatever our body
Right.
is turning to, one takes over, the other goes to sleep.
That's right, exactly right. So cortisol, the hormone that helps us get up out of bed, gives us the energy. It's rising in the morning and helping us get ready for the day. And obviously, if there's a problem, and now cortisol is not just made primarily in the morning, but is now made throughout the day, then that person's body can't actually rest. So they may have trouble falling asleep at night. They, in addition to many other problems. So we try to replace hormones in a way to restore this normal rhythm to the extent that we can, but it's not a perfect science. There are monthly, one more example of an hourly cycle is luteinizing hormone. Luteinizing hormone stimulates the release of testosterone, and it has to be released in small pulses to result in proper production of testosterone by the testes. If luteinizing hormone is made excessively, the whole axis shuts down. And of course, luteinizing hormone also in women has a monthly variation. So in men, luteinizing hormone has a daily variation. In women, luteinizing hormone has a monthly variation, and it's that same hormone that in women stimulates ovulation. So there is this, hormones can have different pulsatility in different people.
So it makes it hard to test them properly. So.
That's exactly right. So for women especially, when you want to measure luteinizing hormone or any of the reproductive hormones, you do have to know where they are in their cycle to try to interpret the levels properly. And even if you do, it's still difficult. It's still difficult.
So as women age and then they're not ovulating anymore, and then there's, menopause and they're going through different issues with that, does that happen with men too?
Oh, good. That's a good question. So does an aging have an effect on the sex hormones in men as it does?
Is there as many side effects as women have, or?
There are some, but the thing with menopause in women, the main distinguishing thing between menopause in women and aging of the male hormonal system is that every woman will go through menopause. Menopause is a time that ultimately ovarian function ceases, right? I mean, some women go through menopause at 49, some at 55, but ultimately all women go through menopause, and ultimately the ovaries completely fail in women. In men, although there could be a gradual decline in the sex hormones in men, it's never an abrupt and complete cessation. And in some men, aging doesn't seem to affect their sex hormones very much. If you take a look at a population of men and plot, for example, their testosterone levels over time, so let's say this is 20, this is 40, this is 60, this is 80, whereas in women, if we draw a sort of a hashed line in women, once you get to 50, the hormone plummets and goes to 0, roughly at age 51. In men, some men maintain normal levels through the same level from the time when they were 20 to the time they're 80. Some men decline more rapidly. Some men decline slower. And if you draw a line through all of these and plot it, there's a gradual decline over time. But there are some men whose testosterone levels don't really change with aging, and some in whom it changes more rapidly. It almost never goes, well, it never goes like women to a zero unless there's some other damage to the testes or the pituitary or some other thing that comes along. So menopause is a defined time where hormone production ceases, the ovaries fail. Menopause, or male menopause, is more sort of like a continuum, that it, you know, it's like the dimmer rather than the off and on switch. You know, it sort of dims in most men, but there are some men who don't have a decline.
It's like a midlife crisis, and there's always room for Viagra.
Although Viagra doesn't help with the hormone.
That's what I'm saying.
Viagra doesn't help with the hormone. So,
And the little blue pill.
yeah, so
Yeah, that's a pill that doesn't work at like a growth hormone will work. When you give someone growth hormone, it actually helps increase the growth hormone, but a Viagra doesn't help increase testosterone.
correct. So Viagra
It's more of a function.
is really a medication that increases blood flow to the penis. So all you're doing is getting erectile function. You're not getting libido. You're not getting the hormonal effects. And so the Viagra is not going to be the treatment for a hormonal problem. And I think in men, I always do try to make this distinction when a man comes in with sexual problems. I try to understand, is it sexual dysfunction in terms of erectile dysfunction, or is it a lack of libido?
Right.
The inability to achieve or maintain an erection or erectile dysfunction is generally a problem with blood flow, with nerve injury, things like that. The problem with libido is a hormonal problem usually.
And it's kind of dangerous if they just are being treated with Viagra, because can't that also mean that like a heart valve is blocked? If a valve is blocked, other valves can be blocked, and if they really don't do a full evaluation on why the problem exists, it can be a serious issue.
Absolutely, yeah. So I think the availability of drugs like Viagra, which is now available through the internet or through primary care doctors, is good and bad. I mean, the bad thing is that a man who has sexual dysfunction can access it, but then they never have an evaluation as to why they have that problem, because usually sexual dysfunction in terms of erectile problems are usually vascular or neurological problems. Now, it may not be something that you can really, it's not as easy or straightforward as just a heart valve that you do a heart replacement and now everything is okay, but it may be the small blood vessels that are damaged, or small nerves, and so you may not really be able to correct or reverse the problem, but at least you need to evaluate for that before just giving Viagra. So.
And you can just buy that on the internet?
Yeah, unfortunate. Well,
You could,
it's
from
illegal
outside of the
here,
United
but
States, you can go on
Yeah.
Canadian pharmacies and other places. You can get it. Now, you don't know what you're getting. Sometimes it could be something not exactly the real active ingredients.
Well, the guys in the Midwest, my dad at 80, had that passed around to him in a coffee clutch one morning. And he said, he said, I got high blood pressure that I've been struggling with for years. The last thing I want to have is a heart attack because somebody at coffee thought, gee, this would be a nice adventure.
Well,
That's
Viagra.
what they were doing, and I sat there and I went, they might be little boys, but even though old men, 80, they're still like, I have one adventure left.
So that is the man who testosterone doesn't decline when they're 80.
yeah.
So libido and erectile problems are not correlated. So there was a time when sexual offenders were castrated. So they had their testes were medically castrated or surgically. So they have zero testosterone. Okay. So this was the punishment for sexual crimes in men at one point. So what happens to these men? Well, they have no interest in sex anymore. It cures the problem.
That's what the eunuchs in the ancient times. Didn't have to worry about
But if you now take those people, those men who have zero testosterone, and now show them erotic films, or stimulate them sexually, they get an erection. So they have no interest in sex, so it's not going to be a problem. They're not going to go looking for, you know, for that form of behavior. But so they're not going to be interested in it at all. But in medical studies where they're then exposed to like a film, erotic films or tapes or stuff like that, then erectile function is preserved, because erectile function is just sort of, you know, not necessarily hormonal. Now, if the hormonal problem, the lack of testosterone, happens really early in development, then you don't get the formation of the secondary sexual characteristics. The penis doesn't form properly, and so you may have erectile problems. But that would be if the testosterone problem was really early. These are different processes, and but on the other hand, the other issue is that, let's say that a man is found to have a low testosterone level. So somebody goes in and they have low libido, and the doctor checks their testosterone, and the testosterone level is low, and then puts them on testosterone. That could be problematic too, because the availability of replacement for testosterone, which is easy through a gel or through injections, may not permit the proper diagnosis. You have to try to figure out, why is the testosterone low? Just like you said, you have to figure out why is erectile problems. And sometimes testosterone is low because there's a pituitary problem. You don't want to miss a pituitary problem. Just give somebody testosterone and say, okay, we got the testosterone level normal, but not treat the underlying problem, which is a tumor in the pituitary.
And if high prolactin can make testosterone go low, right?
And high prolactin can make testosterone go low. So the first thing, when a man has low testosterone, the first thing you want to check is their prolactin to see if they have a pituitary problem. In fact, if you have somebody with low testosterone and you treat them with testosterone without checking their prolactin level, is malpractice. Yeah. It's not doing a right investigation. And then monthly, pretty much that ends. In animals, there are some animals that have yearly rhythms. So the panda bear, the giant panda.
I was going to ask, what animal?
the giant panda bear ovulates once a year.
Really?
Yeah, and so and other.
That's why it's always on the news when a new panda arrives.
And that's why they're vulnerable to extinction, because reproduction happens once. It can only happen really once a year. So and there's only like a 4 or 5 day window there.
Unlike a rat that if you have babies every 14 days, I think, or something like that.
Yeah. So there are yearly cycles too. I think that's enough said about the rhythm. What else can we say about hormones that you guys don't already know? Talked about these kinds of things. Well, we have, okay, so the final important point, and then we'll stop and you can ask questions, is that hormones have what we call feedback regulation, meaning that if a hormone, for example, is produced by a gland, let's just give an example. For example, if you have the pituitary gland here, and of course the pituitary gland is regulating, among other things, the thyroid gland, and the pituitary gland is releasing something called thyroid stimulating hormone, and is telling the thyroid gland to make thyroid hormone, which we call T4 and T3. This hormone at the end, the thyroid hormone, can feedback and regulate the production of TSH at the level of the pituitary. So there's a loop of regulation. So although the pituitary gland makes thyroid stimulating hormone, which regulates the thyroid gland's hormones feedback and tell the pituitary, hey, wait, stop, there's plenty of thyroid hormone, don't make any more signal right now, we have plenty. Or if the thyroid is dysfunctional and is not making enough hormone, through positive feedback, we'll tell the pituitary to make more stimulating hormone. So there's this process of feedback regulation where one gland is being regulated by another gland in what we call a axis, in a full circle. So hormones have this regulatory process, and the reason for that is just to maintain a very fine balance of hormone, because too much or too little thyroid is going to be bad for the organism, cause lots of symptoms. So there's this constant feedback, and you can make the same regulation pathways for all the other pituitary hormones as well. So every hormone is being in turn regulated by the end hormone, by the last hormone that the axis is making. So that is a summary of some of the general principles of hormones. The unifying thing about these processes is that they're very, very delicate. They're easily disturbed. The 3 or 4 pathways that I said that disrupt the endocrine system are relatively common. You know, tumors and autoimmune processes. I mean, autoimmune problems of the thyroid can be seen in up to 10% of women.
Is that Hashimoto's?
That's Hashimoto's disease. That's the autoimmune disease that attacks the thyroid. Of that 10%, only 1 or 2% then end up needing to be on thyroid hormone, but that's still a lot of people who have a problem with an autoimmune problem. So autoimmune problems, tumors, receptor problems, and you know, environmental or nutritional factors that we talked about can all affect this delicate balance of hormone production, and the important point that each hormone has to be made in the right amount. Too much or too little are both bad, and can affect not just survival, but day-to-day feeling, the proper amount of energy, proper ability to think and have memory, to you know, for quality of life, emotions, mood, and so on and so forth. So I'll stop there and see if there's any comments from anybody. Yes.
The Hashimoto's.
Yes.
I want to ask about that because I was diagnosed last year with that. But you mentioned something about it's autoimmune and the possible tumors. They've said something about nodules, or it doesn't look real good. But those are not necessarily tumors, are they?
The thyroid gland can have tumors, which we call nodules.
Oh, so they are.
Yeah,
like
yeah.
tumors.
Tumors and nodules are synonymous.
Oh, okay.
Are synonymous. So you can have a gland, a thyroid gland that has tumors. We talked about 30% of women have thyroid nodules. If you look for them, I mean, if you do an ultrasound, these are not necessarily nodules that you can feel or see. But if you were to scan the thyroid glands of 100 women, 20 to 30 out of 100 will have some nodules. Some of them will be smaller and some of them will be bigger. And we have criteria as to which nodules should be biopsied, because you want to make sure that they're not cancerous. But the good thing is that with thyroid nodules, the majority of them are benign. 95% of thyroid nodules are benign. Now, so that's one process that can happen to the thyroid. You can also have an autoimmune process. You can have Hashimoto's disease, which is an autoimmune problem where the thyroid is being attacked by the immune system and is therefore being rendered underactive or dysfunctional. You can also have a person who has nodules and Hashimoto's disease.
They just said it's not pretty thyroid.
And you know, so they could be separate. It's still functioning. That's good news. You could also have what we call pseudonodules, which on ultrasound are lumps that look like nodules, but they're not really nodules, and are just manifestations of the Hashimoto's disease. Because what happens in Hashimoto's disease is the thyroid gland is constantly attacked by the immune system, and then it tries to heal, and then the immune system attacks it again. So there's this constant attack, healing, and what can that result then in scar formation. And sometimes the ultrasound machine will look at these scars or areas of attack and healing, and it looks like a nodule, it looks like a lump, but it's just the process of chronic inflammation, attack, and repair that looks like a nodule, but it's really not a true nodule. So, but sometimes we can't be sure, and we end up thinking, oh, or are fooled that it's a nodule and somebody has Hashimoto's disease, and we do a biopsy, And guess what? The biopsy shows Hashimoto's disease. Not a nodule, not a cancerous nodule, or not even a benign nodule. It's just the manifestation of Hashimoto's disease.
Did you say that with the 30% that would have it, that maybe only 10% will be medicated for it?
No, I said that about 10% of women will have antibodies against the thyroid.
Okay.
So that's a lot. That's 1 in 10 women. If you measure their blood, they make antibodies against the thyroid.
Okay.
But 9 out of those 10 will have normal thyroid function, like you do.
Mine is
And about 1 or 2%, the autoimmune attack will have brought the thyroid levels down, and now they need to be on treatment.
Now, with my
And they have hypothyroidism. Now they have hypothyroidism. So you can have Hashimoto's disease and not be hypothyroid. And in fact, many people can have Hashimoto's disease and have normal thyroid hormone production for a long time.
Do you know how we talked about once at autopsy, they look for like pituitary tumors? Do they look for things like this?
Yeah, so so
Autopsy?
30% on autopsy have, and then 10 to 15% have thyroid cancer on
And they live
autopsy.
their life and just never knew it.
So it was a thyroid cancer that was not aggressive, and most thyroid cancers fortunately are that way, but you can't be sure. When you diagnose a thyroid cancer in a living person, you treat it, obviously, because it's a cancer and you can't predict. But many times people could live a normal life and die from natural causes, and if you look carefully enough, there may be a microscopic thyroid cancer or a small thyroid cancer. 10%, yeah. And pituitary tumors autopsy studies suggest that like right around 1 in 10 or up to 1 in 20 people can have small pituitary tumors. The majority of those people did not suffer consequences of the pituitary tumor as far as we know, meaning that they lived a full life, and at least in terms of years.
Dr. Cohen, can we touch on also, because you said, like you were explaining here, how sometimes too much thyroid from the Hashimoto's, it'll cause like nodules, but they're really not nodules. Same thing I know with, like, I get a lot of patients that, like they, instantly, because there's a nodule on their adrenal gland, they think the high cortisol is coming from the adrenal glands. And they're really just incidentalomas, and they're convinced that that's what's causing,
Right,
problem.
absolutely right. So interestingly, a common feature of the endocrine glands is that they can get tumors. And many times these tumors may be inconsequential. Or as Charmin said, they're called incidentalomas, incidental findings, meaning, so how do we even find them? How did they get found? Well, the person, for example, is involved in a car accident, and they go to the emergency room, and because they had injury from a car accident, the emergency room doctor orders a CAT scan. And the CAT scan shows that, okay, great, there's no internal bleeding and all that good stuff, that there's no internal damage. Oh, but by the way, we saw that there's a lump in the adrenal gland. Obviously, the accident didn't cause that lump in the adrenal gland. That adrenal gland lump was probably there before. Now, when we discover something like that, we do need to test the hormones and make sure that the adrenal gland is making the hormones in the right fashion, it's not excessive or deficient. And then once we have convinced ourselves that it's normal, periodically recheck and refollow it up to make sure that it stays quiet. But a lot of times these are just going to not cause any ill effects over time. We have to be careful and document that there is a hormonal problem before you go after removing an adrenal nodule or a thyroid nodule or whatever, a pituitary tumor.
Because I see, like, sometimes people will have a pituitary tumor because they did have Cushing's. Then later on, they'll find, the doctor will say, oh, but you also have a tumor in your adrenal glands. And then they'll think, oh, I had cortisol from 2 places. But really those are just common when you overproduce too much cortisol.
Yes. Yeah, if there is a lot of stimulation from the pituitary to make cortisol from the adrenal glands, sometimes the adrenal glands become enlarged and lumpy, and so that could be the case. It would be rare to have a person have Cushing's syndrome from an adrenal tumor and a pituitary tumor. I guess theoretically it's possible. But
I've seen it like once or twice in 13 years, but it is very
it's uncommon. I mean, theoretically it can happen because the principle is that the endocrine glands are susceptible to tumor formation. And so can somebody be, you know, unlucky enough to get tumors in both places and both of them are making, you know, the signal for cortisol? The answer is yes. I mean, it would be possible.
Can we touch on really, like, just a little, I mean, it's complicated, but like MEN1 or MEN, multiple endocrine disorder?
Sure. So there are certain genetic conditions that lead to pituitary tumors. So most pituitary tumors, we don't know why they happen. We're not sure. That person didn't do anything wrong. They didn't smoke. They didn't drink. They didn't, you know, have damage to the pituitary during accidents. Maybe. Maybe there's one study that suggests that smoking has a positive effect on thyroid hormone production.
What?
Anyway, there's certain things probably in the nicotine. It's not the smoke. It's the nicotine that may have protective effects on preventing the thyroid from getting attacked by the immune system, perhaps.
Well, we don't want to find out.
But anyway, so pituitary tumors, we don't know what causes most of them, but about 3% of the pituitary tumors are genetic, meaning that there is a genetic mutation that results in that tumor. And these are called MEN1, multiple endocrine neoplasia 1 is the name of this condition, and as the name suggests, multiple meaning more than one, endocrine, the endocrine system, neoplasia means tumor formation. So common tumor sites for MEN1 would be the pituitary, the pancreas, and the parathyroids. So these are the common sites of tumors in MEN1. There's a gene that has now been fully characterized. It's called the menin gene, MEN-IN. You can test for this gene. So if you have a family where you have multiple people who have pituitary or pancreatic tumors or parathyroid tumors, you begin to be suspicious for this. And so that's MEN1.
And they just test that through blood?
You can test the genetic test through blood, yes.
I have a patient now that she has a midget endocrine tumor with carcinoma syndrome, and that would start in the stomach.
Yeah, midgut. It stands for midgut. Yeah. So these are tumors, carcinoid tumors that can happen in the midgut and like the.
But they're hormonal.
They're hormonally active. You know, they're hormone, and sometimes those hormones are not some of the hormones that we talked about, but hormones that are like metabolites or similar properties to serotonin, and so they can get a lot of different weird symptoms like flushing and diarrhea, and it's not because they have menopause or other. They have these serotonin-like hormone production, and it's in the gut. Usually, it's in the gut, and sometimes in the midgut, and they, you know, so sometimes those tumors are part of MEN1 syndrome too.
And that's what she's being tested for is MEN1
Yeah.
too. And I said that was a good thing.
Yeah. Those carcinoid type tumors can be in the intestinal tract and be associated with MEN1.
Do you think, I know you don't know the exact answer, but your best guess that in today's med schools that they're teaching more and more about hormones, or is it still not really being, unless you're specializing in an area?
I do think, I mean, I haven't been in practice long enough to give a very good answer to that, but even in the short time, in the last, I think, 15 years, I do think that there's more awareness of hormonal and pituitary problems.
Yes, because we've all worked very hard to make
I do think so. I think.
But I'm wondering if at the education.
But I don't know if it's translated into the medical school curriculum, and I don't see it necessarily. I mean, I'll tell you, in medical school, for the second year, they have, because I used to do this lecture, they have one 60 or 80-minute lecture on the pituitary in the second year.
That's it.
Yeah, I used to go in with them to do that talk, and half of the people were sleeping.
Yeah, so if you sleep through that lecture, you may miss pretty much. Now, there's some repetition in medical school training. So if you sleep through that one lecture in the second year, you would have got some pituitary when you did anatomy in your first year. You know, you dissect the pituitary gland. So if you were inquisitive, you would try to think, okay, well, what does the pituitary gland do? So you get some anatomy in the first year, you get physiology in the second year, and then, you know, then I think if you don't get that, or you don't have the interest and you don't get it, then it could be problematic, because then the pituitary problem may not come your way. You may not see it in your clinical years when you're rotating in the hospital, and you may not see it in your residency too much. So yeah, I think, I don't know, I think general awareness among patients has definitely increased through organizations like you, Christina, and Charmin have led, and other organizations. I do think that there's much more awareness and support in the internet era. I mean, I've had some people diagnose their own pituitary problems, and they're 100% right. You know, Google can.
When I diagnosed myself, we didn't even have Google. I just happened to get lucky and put on it, and I found it. But now things have changed. I mean, even in 13 years, the amount of, now there's support groups, and there's people doing blogs, and I think now, you know, much more than in the old days, which I think, even though I haven't seen it in the medical schools firsthand, but I do believe, because the public is becoming more aware and the public is becoming more educated, that it is going to be eventually forcing medical doctors to be more educated. And I think maybe I've seen a little bit of the younger generation actually seeing that this is a bigger problem. So I think we're moving in the right direction, even though maybe we've only moved a golf ball 1 inch closer to the sun, but it's going in the right direction.
Yeah. And then, of course, you know, if a clinician who I think is a good doctor learns from their patient. So if a patient, you know, ultimately goes to their doctor and says, you know, I'm worried about a pituitary problem, and that person ends up having a pituitary problem and is diagnosed, then hopefully that will reinforce that doctor to read up more about pituitary problems, to think about it with the next patient that walks in who may have similar symptoms.
But didn't Dr. Kelly also say it's still worldwide the most misdiagnosed pituitary?
And do you I hope that today's little discussion gives you an idea of why that is. You know, like so somebody who comes in who has this terrible disease, Cushing syndrome, and you don't understand that, number one, that cortisol is a hormone that's a steroid hormone that's bound to carrier proteins, and you try to just measure it in the blood, you're going to be misled. Or if you measure it at the wrong time of the day, you know, you're going to be misled. And so the problem is that this, even if you have appreciation that this is difficult, you have to, you know, perform the right test, because these hormonal
and usually more than once, correct?
Usually more than once. Usually you can't just do a single blood test to diagnose a pituitary tumor. You may have to do a dynamic test. It could be a 24-hour urine test. It could be a suppression test. It could be a stimulation test. So.
But even if it's not a pituitary, like I was telling Dr. Cohan, I have a girlfriend that was having a lot of anxiety. And her doctor looked at her thyroid and realized that she had, I guess, hypothyroid, and put her on Synthroid, and she told me she's never had another anxiety attack. You know, and I didn't know those two things were related. So she doesn't have a pituitary tumor, but would your average doctor look at your thyroid? Or would they give you, here's some
hopefully they do.
You know what I mean?
That's
where I'm going.
Here's your Prozac.
Here's your Prozac, go home. He looked
Well,
further and said, oh, you
What I find is, because most doctors say, I specialize, like you'll see on a business card, and it says, I'm an endocrinologist, and it says, I specialize, thyroid specialist. Okay, well, if you're an endocrinologist, you should have every kind of endocrine specialty. However, we don't have that. We have endocrinologists that specialize in diabetes and in thyroid, but they don't necessarily specialize in the neuroendocrine section.
Well, this was a
But-
GP, going to a general
But
practitioner.
one of the
saying,
most
"I'm having
common
this."
symptoms of thyroid is that you have anxiety, your heart races, or you feel sluggish. So they know I think in general, most of them will test your thyroid. Now, the problem with that is, yes, now this general doctor puts her on Synthroid, which is fine, it seemed to work for her, and I know this person, and I don't believe she has a pituitary tumor, but I've seen plenty of times where the patient say, I have anxiety, which I even said, I had anxiety, and the first thing they did is they put me on large levels of thyroid, and because they put me on tons of thyroid, which then my heart races more, and I have more anxiety, and the weight gain keeps coming, and so then they're like, oh, and I keep telling them I'm gonna have a heart attack. So we have to, again, going back to, you can't just put someone on testosterone without finding the problem. You shouldn't really put someone on thyroid without understanding what's going on with their thyroid. Like, why is her thyroid making her heart race? Just doing it maybe because it's low, maybe because it's high, or whatever, but, or giving her anxiety. But there should be some kind of protocol that you really rule out and know what's going on with their thyroid before you stick them on Synthroid.
If you recall, my macroadenoma at the time was the size of a golf ball. And Dr. Kelly said, I'm the only patient he ever had who had no headaches. I had no headaches whatsoever. And he said he's never experienced that. And I discovered it basically in a training ride on Sunday in Griffith Park. A guy went by me here, your peripheral vision is here. A guy went by me, I didn't see him till he was here.
Yeah.
And I said, that's kind of odd, So immediately, I was conscious of it, went after it, and some nitwit in Century City said to me, you got glaucoma. Well, usually you don't have glaucoma in your 40s,
Peripheral
Wow.
vision.
And so I went to Jules Stein, right here. And the glaucoma guy looked at me for 1 second. He said, stay here. The nerve specialist came. What's his name, Dr.
Arnold, Anthony Arnold at that
Arnold,
time.
yeah, very, very stiff kind of, yeah.
Yeah.
Anyway, Arnold looked at me and he said, your left nerve is extremely pale. The right is beautifully, circulated blood, and etc. So he said, you should have an MRI. So I went across the street the next day, and there it was, and that's how we met,
Wow.
And Kelly said to me, here it is. It was the size of a golf ball. I had no headaches, nothing.
So that's why it's important that we don't just always just take pills without finding out, like, really why we need to, doing sometimes maybe asking if a general doctor says, I'm gonna give you thyroid, maybe ask to be referred to an endocrinologist to get a second opinion before you start, that's what I would do.
I think that's the right way to go. To get another opinion is always good, and also to appreciate that sometimes the same hormonal problem in two different people can cause vastly different symptoms.
Yes, absolutely.
So that's why it's hard to sometimes just categorize, okay, well, this is the symptoms of thyroid. The example that you gave me, I think, was that she didn't have anxiety all the time. She would have anxiety during her menstrual cycles,
In the
right?
mornings or something.
Or something like that. It was a
Well,
periodic
that's me.
periodic
I
anxiety.
don't know hers.
So sometimes
She was just having anxiety
you can
once
have
about
you can have one manifestation in somebody, having hypothyroidism, having symptoms during certain times of the month when other hormones are active, causing problems with sleep, too much, too little, either one, with the same hormonal problem.
Too much. I like to sleep.
Well, it's getting late, so we want to say thank you.
No,
you're welcome.
Dr.
You're welcome.
Cohan. Always so